Peace be upon you all, dear respected attendees. Welcome to the Health Awareness and Education Program on Diabetes, introduced by Saudi Charitable Association of Diabetes with guidance of Board of Director members. We are pleased to introduce our educational program today entitled with Nursing and Diabetes. According to our schedule announced before, for your question, you can send them to be answered in chat or in question and answer square. For attendee certificate, there will be a link. It's going to be sent at the end of our webinar, inshallah. And now we are going to start our event with Dr. Muhammad Al-Mehdal. Welcome, Doctor.
Bismillah ar-Rahman ar-Rahim. Thank you very much for the introduction. I'm Dr. Muhammad Al-Mehdal. I'm a consultant in endocrinology, diabetes, and eye transplantation in King Fahd Medical City in Riyadh. I'm also the chairperson of the diabetes department and the diabetes fellowship program director. I'm also a clinical associate professor at the University of British Columbia in Vancouver. Today, I will talk about the stem cell-based therapy for diabetes, and I thank the organizing committee for inviting me to give this lecture, and I hope you find it useful. I have no disclosure relevant to my presentation today. These are the outlines of my talk today, and hopefully we'll cover it in the next maybe 20-25 minutes. I'll start with a case who is a 48-year-old woman who has had type 1 diabetes since the age of 3 years. She was on sensor augmented therapy when we saw her with total daily dose of 30 to 35 units. And her diabetes is complicated by retinopathy, peripheral neuropathy, microalbuminuria, and mild chronic kidney disease with GFR of around 55 ml per minute. We know the pancreas is composed of two parts, the exocrine, which is the largest part of the pancreas, and the endocrine part, which is comprised only maybe 2% of the whole pancreas. And the endocrine part composed of mainly endocrine cells, including the beta cells, which constitute around 65 to 85% of the endocrine part of the pancreas and secrete insulin. Then followed by alpha cells, which constitute around 15 to 20% of the endocrine cells of the pancreas, and they secrete glucagon. Then there are other cells which is less abundant than the alpha and beta cells, including the delta cell, which secretes somatostatin, PP cells, which secrete pancreatic polypeptide, and also epsilon cells, which produce ghrelin. Here you can see on the x-axis is the critical and is the time, and on the y-axis is the beta mass, and this is the critical beta cell mass, which is required to maintain euglycemia. We know that type 1 diabetes started with genetic predisposition with one or more triggers, usually environmental triggers, insulitis or inflammation of the beta cells in start. And this stage is characterized by multi-antibodies positivity in the blood. With further decline in beta cell mass, prediabetes happen, which is characterized by the loss of the first phase insulin response. With further decline in beta cells, full diabetes happens. We know from DCCT trial, which is the landmark study in type 1 diabetes, that intensive glucose control around 7% compared to conventional treatment at that time was associated with significant reduction in microvascular complication, as we can see here. However, with the decline in microvascular complication, there was an increase in the incidence of severe hypoglycemia, which is associated with cognitive dysfunction, loss of consciousness, seizure, and death. Additionally, we know from the EDIC trial, which is a continuation of DCCT trial. We can see here, this is the end of the DCC trial, and the active group reached hemoglobin A1C around 7%, And after that, they both treatment arms enter in an open label phase of the trial called EDIC, where they included in the intensive insulin therapy or intensive control. And we can see here the achieved hemoglobin A1C was around 8%. This is also reflected again by the type 1 exchange group, which is multiple diabetes centers all over North America, and they published their experience, and you can see the hemoglobin A1C according to the age, and we can see, which is understandably we see in our practice, especially in adolescent, the control is not very good. Even in adults, the control is always or most of the time above the 7% range. So in the best centers or all over the world, it is even difficult to reach the target hemoglobin A1C of less than 7%. So patient or scientists try to figure out other treatment modalities other than exogenous insulin injections. So the idea of beta cell replacement came out, either pancreas or islet transplantation, or from stem cell therapy, which is converted to beta cell then transplanted. Other treatment tried is immunotherapy and gene therapy, which are not the topic of our lecture today. So beta cell replacement therapy started with whole pancreas transplantation by Dr. William Kelly, who did the first transplant in his patient, Richard Laley, and this was 1966. Which was performed at the University of Minnesota. And we can see here, we can concentrate here on pancreas transplant alone. And you can see the insulin independence at 1 year is 78% of the patient. They're not using insulin at 1 year. And at 5 years, 54% of the patient are not using insulin. And I want you to remember those figures, so we will compare them to the islet transplantation. So what are the challenges which faced by the pancreas transplant? First, the organ supply. There is no enough organs to meet the demand of the treatment. Other side is the surgical morbidities, because pancreas transplant is a major surgery. It can be associated with morbidity and mortality. And also the patient will be on immune suppression for the rest of their life with all the complications associated with immune suppression. So the other thing, or other beta cell replacement therapy, was the islet transplant. And probably you recognize the scientist. He's Paul Langerhans, who discovered the islet of Langerhans in 1869. And since that time, people was trying to discover the treatment from the islets, and many studies has tried islet, but with no success until 2000, when Edmonton Group published their study of 7 patients who reached insulin independence after islet transplantation, and they used glucocorticoid-free immunosuppressive regimen. After that, centers all over the world for islet transplantation has opened, and the treatment has explored or tried more often. The procedure itself starts with isolating the islet in the islet lab by first injecting the collagenase enzyme in the pancreatic duct, then dissolving the exocrine part of the pancreas, then centrifugation in Ricordi or chamber or Ricordi chamber, and after that purifying the islet to be ready for transplantation into the diabetic patient. After purification of the islets, then we percutaneously access the portal vein, then inject the purified islets, and this is done in under conscious sedation in interventional radiology suite. Then after that, after injecting the purified islet in the portal vein, they flow into the liver sinusoid, and they get stuck there. And after that, they start to establish a blood supply, then start to secrete insulin. And we can see insulin independence rate after islet transplant. And in the first year, around 50% in the beginning. And at 5 years, it reached around 20-25%. This is the old information we have. But more recently, after improvement of the immune suppressive regimen and the procedure, this is the pancreas transplant alone, insulin independence rate, and this is islet transplantation alone, which is comparable to each other. It's not significantly different from each other, and they reach really good proportion of insulin independence at 5 and 6 years, above 50%. What about the C-peptide? C-peptide is detectable in most patients, even 5 years after the transplantation, which is a good marker for graft function. A1C, and you can see after transplantation, the A1C is most of the time below the target, which is 7%. And in addition to the good hemoglobin A1C, there is a reduction in severe hypoglycemia and hypoglycemia unawareness. And you can see the orange color is the severe hypoglycemia, and you can see very small proportion of them, they continue to have hypoglycemia or severe hypoglycemia after transplantation. You have to keep in mind that we transplant patients who usually have severe hypoglycemia. So this is a good achievement, and it's associated with good quality of life. So we know that transplant now works. So who should get the islet transplant? So there is no brainer to say that people who already have kidney transplantation and they have a problem with their diabetes control, they can receive islet transplantation because they are already on immune suppressive medication. Patient with what we call brittle diabetes or unstable diabetes, especially if associated with severe hypoglycemia or hypoglycemia unawareness. So they are a candidate for islet transplantation. Some clinical trials, especially from our group in Vancouver, are addressing the impact of islet transplant on the complication of diabetes. So, however, with the pancreas transplant, we have some challenges with the islet transplant, including the organ supply. And this is a major problem, especially that achieving insulin independence usually require 2 to 3 organs. Again, the patient have to be on immune suppressive medication for the rest of their life. So with all the complication associated with that. And the other thing that we lack the early markers of rejection, because we usually measure C-peptide and glucose. And when they are, when the blood glucose is high and the C-peptide is low, it's usually late to intervene and prevent rejection. Then the shortage in the supply triggered the enthusiasm in trying to find a source for beta cell which can meet the demand. So lots of research now is being done on the stem transplantation. And to understand this better, let's talk about the basics and define what is a stem cell. Stem cell is a cell that can replicate itself, differentiate into many cell types, including the beta cells. So we start with the stem cell, which can be triggered to be a mature cells, like in beta cell in our case, which can be used for stem cell therapy or disease modeling to study the disease like diabetes, or drug screening and development for diabetes, and or gene editing to try to cure or prevent diabetes in susceptible people. So I will leave you with this short video clip to understand the embryonic development, so you understand the stem cell. Okay, so the pancreatic bud comes from the endoderm, and there are several types of stem cells, which we will talk today about: the embryonic stem cells, induced pluripotent stem cells, adult stem cells, and cord blood stem cells. As you have seen in the video, the embryonic stem cells comes from the inner cell mass, which form the entire human being. So they harvest the inner cell mass in outside environment, and they call it stem cell line. Then use it for different things like stem cell therapy and other modalities we talked about. So there are, with this, there was an ethical dilemma, because if we take the inner cell mass from the embryo, or the blastocyst, we potentially kill a human being. So that was an ethical issue with the embryonic stem cells. And to overcome this, scientists try to do the what we call induced pluripotent stem cells. What does that mean? They take a somatic cell, like a skin cell, then they added special factors to reverted to a stem cell which can differentiate into other cell types. And we call this embryonic or induced pluripotent stem cells. And this discovery was done, and the two scientists who discovered this, they won a Nobel Prize in physiology or medicine in 2012. Probably those who are active in this field, they know the two scientists who are Shinya Yamanaka from Japan and John Gordon from England. So those were granted the Nobel Prize in 2012 for their discovery of the induced pluripotent stem cells. And the other type, or the third stem cell type, is the adult stem cell type, which is present in our body. They are multi or unipotent stem cells, and the examples are hematopoietic stem cells, which can be differentiated into different blood cells, skin stem cells, which can differentiate into adult stem cells, and mesenchymal stem cells, which can differentiate into all the connective tissue cells. And the fourth type is the cord blood stem cells, which is taken from the cord blood. And there are two types: the hematopoietic stem cells, which can differentiate into blood cells, and the other one is mesenchymal stem cells. So the potency, it is different from cell to cell. So the most potent one is we call it totipotent, which is produced by the first few division of the cell and can form any cell of the embryo and the placenta. We call it totipotent, and usually they are the fertilized oocyte or morula. The other one is pluripotent stem cells, which can differentiate into cell derived from the three germ cell layers that we talked about, like ectoderm, endoderm, and mesoderm, and these are the embryonic stem cells. Other ones are the multipotent stem cells, which can produce cells of a closely related family of cells, like the hematopoietic stem cells and mesenchymal stem cells. Unipotent stem cells, which can only produce one cell type, like epidermal stem cells, which can only produce skin fibroblast. And the fully developed or fully differentiated cells, which cannot differentiate to any other cell. So how do we generate beta cell from the hematopoietic or the human pluripotent stem cells? From embryonic stem cells or induced pluripotent stem cells with a special juice, they can be differentiated into definite endoderm, then primitive gut tube, then posterior foregut, then pancreatic endoderm, pancreatic endocrine precursor, immature beta cells, and mature beta cells, using all those factors listed below the cell itself. And this has been successfully developed in vitro and used for first phase 1 and phase 2 trials of stem cell therapy. So what are the limitations? The ethical issues we talked about in the embryonic stem cells, immune attack to the transplanted stem cells. That's also another challenging thing, and lack of early markers like in the islet transplant for rejection. Then the other possibility of tumorigenesis with the stem cells, like teratomas, which can develop with those stem cells. So to overcome the immune attack on the cells, people started to develop what we call it encapsulation of the stem cells. And there are two types: the microencapsulation with alginate and macro encapsulation in a big device, which can prevent the attack of the immune system, but allow the blood and nutrients to enter to the device. I worked with one company called ViaCyte, which are doing now phase 1 and 2 trials for stem therapy, and they're using pancreatic endoderm, and they put they start with cell line and differentiate it into the pancreatic endoderm. Then they encapsulate it in a delivery device, then transplant it or implant it under the skin of the patient. And you can see here, this is the encapsulation device. They have a small one and big one, and this is their size compared to quarter. and they fill the device with their pancreatic stem cells to allow them to differentiate. The first phase trial done without immune suppression, but it was noted that fibrous tissue was formed around the encapsulation device and prevent blood supply. So that's in phase 1 trial. So they made in phase 2 trial, they made the holes into the device for the blood cells to enter, but they administered immune suppressive medication to prevent the immune attack on the stem cells. So far, there is no formally published trials on their studies, but from what we've seen with our patient, it is encouraging, and we have seen C-peptide detectable in our patient with reduction in insulin dose. So I think in the stem cell field will explode in the next few years, and probably we'll see it in real or clinical practice in maybe 3 to 5 years. So let's go back to my case, a 48-year-old woman who has type 1 diabetes, and her control was not really good. She had frequent hypoglycemia more than 10 times per week, including 1 to 2 times severe episode of hypoglycemia, which requiring glucagon administration by her husband. Her A1C was ranging between 6.9 and 8.5. You can see here a continuous glucose monitoring tracing, and you can see what we call brittle or unstable diabetes. She received islet transplantation 3 times in 2003, 2008, and 2014. And you can see on the left, before transplantation, her blood sugar on the continuous glucose monitoring. And after 9 months after the last islet transplantation, you can see her blood sugar where it is very consistent in the good range without hypoglycemia. And this is her A1C. This is 7%, and this is A1C all over the years. This is the first islet transplant she received. This is second, and this is the third one. And her most recent A1C in the 6 range without hypoglycemia and without insulin. So no hypoglycemia since first transplant. She required insulin briefly before her second and third transplant in 2008 and 2014, but she is insulin-free since 2014. So in summary, cellular replacement therapy may offer the best approach to achieve physiological glucose control in diabetic patient. The expansion and subsequent differentiation of stem cells, be they of embryonic, fetal, or adult origin, appear to have considerable potential to overcome the shortage of donor organs. I will stop here, and I don't know, do we have time for questions? Riham, I think we will maybe leave the question at after the second talk, then we can take a question for both talks.
Okay, I think it's better.
Okay, so now I think it is my pleasure to introduce Dr. Elizabeth Abu Jawde. She is an assistant professor at the medical school at the Holy Spirit University at Kaslik, Lebanon. She is also the head of the Middle East Diabetes Center in Zouk Masbeh in Lebanon. She is the head division of endocrinology at Notre Dame de Liban University Hospital in Jonia, Lebanon. She is also a consultant endocrinologist at Beirut Eye Specialist Hospital in Beirut, Lebanon, and consultant endocrinologist in the Middle East Institute of Health University Hospital in Bsalem, in Lebanon, and consultant endocrinologist at Boulevard Clinic, Badaro, Lebanon. She's also a former assistant professor at the Faculty of Agriculture and Food Science at the Holy Spirit University. And she has lectured in many local and international conferences, and has many publications in endocrinology and diabetes. I welcome you, Dr. Elizabeth, and it's a pleasure to have you today with us. And please go ahead.
Thank you so much, Dr. Muhammad. Thank you for your excellent lecture. Really, the stem cell therapy are the future for our patients. They are all hoping for the therapy so they can get rid from the insulin, like just your patient. She's free of insulin since 2014 and her A1C is excellent. Thank you so much for the organizing committee for giving me this pleasure and honor to be with you tonight and to talk about time and range. So does time and range matter? This is my disclosure. I have nothing to disclose in this particular subject. The objectives I will go through tonight: how to compare and to contrast the benefits and the drawbacks of measuring time and range and A1C for our patients with diabetes. The second point, how to interpret an ambulatory glucose profile report in CGM data. And the third point, how to evaluate if we improve the time and range, we can improve the complications in our patients, microvascular and also macrovascular. So I have been practicing since around 10 years, and we had really many medications. We had the new insulin analogs, then we had the GLP-1 receptor agonist. Later on, we had the once weekly GLP-1 receptor agonist. We had the new combination of insulin plus GLP-1 receptor agonist. And lately, we had the oral GLP-1 receptor agonist. So with all these new classes, for 10 years, we had all the CVOT trial, the cardiovascular outcome trial for DPP-4, for GLP-1, for SGLT2 inhibitors, and all the CVOT had changed the way we are treating our patients. We had it changed in 2016 after the EMPA-REG outcome trial. We had it change our patients having cardiovascular disease, chronic kidney disease, heart failure, or even they are at high risk for these diseases or no. So all depends on the CVOT trial. And also we had the innovation of the CGM. We had the Dexcom, we have the Freestyle Libre, and also we have the insulin pump plus the sensor. Let's talk, for example, let's take the Freestyle Libre. It's a fully disposable sensor that a patient wear for 14 days. There is no need for any finger stick calibration. The sensor automatically will measure, will capture, and will store all glucose data. Do you think that we should say a goodbye to a very old good friend, which is the HbA1c? Let's see. In this particular graph, we see two different patterns. We have the same A1C, but we have different variability. In the red line, we have high variability between hypo and hyper, and in blue or violet, we have small variability with the same A1C. Okay, I'm sorry, just 1 second. So, if you can see, we have the same A1C, we have the same destination, but we have different routes. Which one is the most dangerous? The first one, of course. So if you can compare also these two graphs, the same A1C, but we have different excursion, different variability. And the A1C by itself cannot track the glycemic excursion. 60% of the glucose lows or the hypos may not be revealed by the self-monitoring blood sugar. And the CGM will identify 4 times more serious glucose variability and glucose excursion than the self-monitoring blood sugar. What are the reasons for the blood glucose change? We have almost 42 factors that can affect our glucose. Let's start by the food, the carbohydrate quantity, the type, the fat, protein, if they are taking alcohol, the medication dose, timing, any interaction, the activity of the patient, whether they light exercise or high intensity exercise, the time of the day, and many biological factors, like, for example, insufficient sleep, stress, puberty, smoking, infusion set issues. Many factors can affect the blood glucose. We have three patterns, 3 CGM, that drives the same A1C. But which one is the most dangerous? If you can see, the number 2 has the higher variability and the most dangerous one. What are the limitations of our old good friend, which is the A1C? We have variability in the measurement and many conditions affecting the hemoglobin, like, for example, thalassemia or anemia, iron deficiency anemia, or chronic kidney disease. Many conditions can affect the red blood cell turnover, and this will also limit the A1C. It does not reflect any variation in the glucose, and the A1C can be overinterpreted. When assessing a patient, whether he has type 1 diabetes or type 2 diabetes on multiple daily insulin injection, what's your primary concern? The glycemic control, the A1C, the hypoglycemia, the diabetes distress, or diabetes complication? I think we all agree that hypoglycemia is the most important factor and the fear for all the patients having diabetes and treated by insulin. In this study, we can see that subjects achieving an A1C below 7%, which is an excellent control, they experience around 60 minutes per day in hypoglycemia. So A1C by itself does not tell the full story. This is the history of the glucose monitoring. It started in 1945 by Clini test. It's a urine glucose test with the copper reagent. And we have many development through all these years. In 2014, we had the Freestyle Libre, the CGM that really changed the life of our patients. In 2016, we have the Dexcom. So a reliable CGM is a turning point in the management of diabetes. What are the principles of CGM? We know very well that there is a difference between the CGM and the glucometer. And all our patients will tell us that I measured by the glucometer and that's different than my Freestyle Libre. Of course, because the glucometer will just have one reading in the blood vessel. So the glucose in the blood vessel. While in the CGM, we are monitoring and taking data, capturing the data from the interstitial fluid. And there is a delay time between the blood vessel and the interstitial fluid. So you can see that the glucose will enter the interstitial fluid and the sensor will have a capturing of this reading. The 7-point SMBG, we can take pre-breakfast, post-breakfast, pre-lunch, post-lunch, pre-supper, post-dinner, and at bedtime. Then we had the typical CGM profile, and now what we have is the ambulatory interpret an AGP. How to construct an AGP? So we have seen the A1C, we have seen all the limitations. Now let's go to the CGM and the AGP. The patient is doing many scans. You can see many points and many scans. We will take the median curve of these all points. Then we will take the 25th to 75th percentile. And then the outer lines are the 10th to 19th percentile. This is how we construct the AGP. What is time in range? It's the duration of the patient blood glucose within the target range, 70 to 180 milligram per deciliter. And each patient or each doctor can put the time in rate according to each patient profile. It's very important to interpret the time below range, the hypoglycemia, and the time above range, the hyperglycemia. It's very important for those with frequent variability and excursion beyond the threshold for hypo and hyperglycemia. It's also very helpful to distinguish whether a given intervention, if for example, I'm increasing my insulin dose or I'm decreasing my insulin dose, how this will affect my AGP. We can see here 3 graphs. The first one, 0% time in range, all above. The second one, we have 50% time in range. And the third one, all between 70 and 180, we have 100% time in range. What's the difference between A1C and time in range? A1C, it's a single A1C level, while in time in range, we have a continuous glucose level evaluation. The A1C, it's every 3 months. So we can compare every 3 months the A1C. While in time in range, we can compare day to day, or for any given amount of time, we can see the glucose fluctuation. In A1C, we cannot predict any hypo or any hyperglycemia occurring in the same day. While in time in range, we can capture all glucose levels for a given time and to identify if we have hyper or hyperglycemia. In HbA1c, it's less likely to capture impact of any acute intervention, as we have seen, and for the time in range, we can see it immediately. What about the relation between A1C and time in range? For every 10% increase in time in range, we can decrease the A1C by 0.8%. So every 5% in around 1 hour per day increase in time in range will have clinical benefits. This is a correlation between time in range and A1C. In February 2019, in Berlin, in this Congress, they have put the time in range consensus. For type 1 and type 2 diabetes, patients should have more than 70% time in range, so between 70 to 180. What about hypoglycemia? Below 70, it should be only below 4%, and below 54, it should be below 1%. While for hyperglycemia, between 180 and 249, it should be less than 25%, and above 250, below 5%. It depends if we have elderly, high-risk patients, if the patient is pregnant with type 1, or we have pregnancy, type 2, or gestation. All these time in range can differ. These are the consensus developed in Berlin 2019. So for the time in range, it is striking the balance between hypoglycemia and hyperglycemia. So above 70% in the time in range, below 1% for the severe hypo, and below 25 and 5% for the hyperglycemia. How we can interpret? We have this consensus, and we have the Libre view for the freestyle Libre. We will see it and develop it. This is the reader report. We can see the daily pattern, the last 7 days. We can see the time in range, for example, here it's 54%, so it's below 70. The patient is not doing very good. What about the Libre view? We can connect the account of the patients to our laptop and have a full understanding, a full graph that we can interpret with our patients. We have the AGP report, we have the time in range, we have this graph AGP, and we have the daily glucose profile. So for the glucose statistics, how is the percentage the CGM is active? It should be above 70%. Here it's 88%, which is very good. The glucose management indicator, what is this? It's approximately the A1C level that would be expected according to the average of glucose we have in the CGM data. How we can interpret the graph? First, we should always start by the hypoglycemia. Are there any patterns of hypoglycemia? Then we see the readings are within target range. What is the shape of the median curve? We're gonna do an example together. Then we're gonna measure the glycemic variability. It's measured just here. This is the glucose variability, 31.5%. So we took the standard deviation, we divided by the mean, and we have the coefficient of variation. It should be below 36%. If it's above or equal to 36%, that means that we have unstable glucose levels. You can see we have 4 graphs. Patient 1, 3, 4, 2, all we have different A1C or estimated A1C. You can see the lab A1C is 8% for all of them. But here we have different advice for the same A1C. Let's see. Here we have a hyperglycemia post-breakfast. Here we have hyperglycemia post-dinner, and we have low at night. Here we have post-lunch, post-dinner, hyperglycemia. So we need to interpret our AGP and to give many advices for the same A1C that be different for each patient. So for the first, we ask the patient to put the type, duration of diabetes, the age, the weight, and the insulin dose. Then we can also help him put the usual times for the waking, the meals, and the bed, the medication taken, the time of the medication, and also if he does any exercise or take any snacks. Second, we can see the 10% line. If it touches the lower target, means we have hypoglycemia, and then action should be taken. If this will touch the 25% line, touch the 54, means we have severe hypoglycemia and an immediate action should be taken. We ask the patient about the medication, about the insulin taken before meals or during meals. All these to interpret the AGP and to take action, but always start by hypoglycemia. So let's check the step 1. We have 9 steps to interpret the AGP. The first one is we need data sufficient above 70% of the 14 days of the data. The CGM should be active more than 70% of the time. The second one, mark up the AGP. So we put the medication taken, metformin, for example, Degludec-Lispro, at what time, the waking time, the breakfast, lunch, dinner, and the bedtime snacks, and small details about the patients. Then we're gonna see the target in range. Time in range is 47%. It's very low. We're gonna ask the patient, what do you see? He see, for example, here, hyperglycemia, and here hyperglycemia, and here we have hypoglycemia. So the patient is doing hypoglycemia at night. What we should do? We should decrease the basal insulin from 20 to 16, and we should also check the correction factor. Then we see now the hyperglycemia. So after we see the hypo, we can see now the hyper after breakfast and also after dinner and at bedtime. The glucose variability is about timing and amount of the carbohydrates. We're gonna check the insulin to carb ratio, the exercise intensity, the insulin taken, and the carb counting and the correction factor. All these has to be taken into consideration. The 7th step is to compare the past AGP and to reinforce any successful strategy taken. And each strategy needs time to be to have been shown on the AGP. So for the first lows, we decrease the long-acting insulin. We check the correction factor. We reduce the variability for the insulin timing, the amount of food, and to consider the carb ratio. We treat the hypos, then we treat the hyper. The step 9 is to copy the AGP for the patient and to give it to them. This is very important to interpret the AGP in front of the patient and to help them understand what's about AGP, hypo, hyper, what we are doing to help them improve their glycemic variability. So we have seen the difference between A1C and time in range. Then we have seen the AGP interpretation. What about time in range and complications? Does time in range have any association with diabetic complications? This is an area of emerging data, and we have a lot of new data that you are seeing every day. From the DCCT trial that Dr. Muhammad had developed, they had taken 7-point testing, and that had demonstrates that the time in range is strongly associated with the vascular complications. For each 10% decrease in time in range, we had 64% increase in retinopathy and 40% increase in microalbuminuria. What about the macrovascular complication? For the carotid intima media thickness, this is another study that showed when we have a high percentage in time in range, we have low complication in the carotid intima media thickness. I will end by some tips in the patient education. Data is neither good or bad. We need data to improve the glycemic variabilities. We need to identify the bright spots, to review the glucose targets, to see the arrows. For example, if the patient has an arrow down when he is going to bed, means the patient will do a hypoglycemia during night. That's why he should take, for example, a snack, or he has to decrease the basal insulin. If he is going to bed with a high arrow, means he will do a hyperglycemia, so no need for snack. We should put SMART goals for our patients. S for specific, M for measurable, attainable, relevant, and of course is time bound. For the meals, we should explain to them the effects of the food intake relative to insulin dose. And after meals, he has to scan hourly for the first 4 hours post-meal. If the patient is doing exercise, he should do the scanning before, during, immediately after, and 6 hours after exercise to see if we need to decrease the insulin dose, for example, or to stop insulin completely. During illness, during sleep, if anyone can scan it for him. The post-insulin dose correction, never correct a high within just 2 hours. If the patient is taking the MDI, multiple daily insulin, after 2 hours, we consider half the correction. We have many tips to increase the time in range. The most important is to test frequently. If the patient is just testing 4 times per day, we can have 48% time in range. While if it is testing 40 scans and 40 times per day, he can reach a time in range of 70%. And the estimated A1C can be 6.7. And the patient will be very controlled. So we have the A1C, we have the fasting plasma glucose, we have the postprandial glucose, which are very important for our patients. But now we have a 4th domain in glycemic control, which is the time in range, which is very important to help our patients improve their glucose variability, glucose levels, and glucose control. In summary, we have to overcome all the barriers of the patient and clinicians to put and to install the CGM. We have novel parameters now for personalized glucose control. The time in range, we have the AGP and we have the arrows, trends. We have a strong association between TIR and the microvascular complication as well as macrovascular complications. Although A1C is considered till now the validated glycemic metric as a measure of hyperglycemia for clinical trials, it's not a good indicator for the glycemic control for hypo and for hyperglycemia. We need to understand the data. we need to help our patients also take action. Living with diabetes is not easy, but it's easier now with CGM. So all those patients are your patients, are my patients. They can be our mother, father, daughter, grandmother. We need to help them. So help keep your patient's glucose steady, tight, and in range. Thank you.
Thank you very much, Dr. Abu Jawde. That was very nice lecture on the time and range and the importance of time and range. Do you think, Dr. Abu Jawde, that will replace A1C in the future?
Maybe it can replace the A1C if all the patients can put this sensor. And day after day, we have an improvement in the accuracy of the sensors. So maybe one day we don't need anymore the A1C.
Okay, thank you very much. I don't see any questions so far. Yeah, if you have any question, please type it on the chat window. Then we'll answer them maybe after the next lecture. At this time, it is my pleasure to introduce Dr. Nizar Al-Bash, who was born in Aleppo, Syria in 1953. He was graduated from the Franchi Comte University. I don't know if I pronounced that the right way or not, in 1980, and post graduate you hear me? Okay. Also he postgraduated on diabetes and endocrinology from the same university in 1984. From 1986 to 2012, he has been an associate professor and consultant in internal medicine department at Aleppo University in Syria, and the head of the diabetes research unit at Aleppo University. He is currently a consultant at the endocrine and diabetes department at Hotel du Hospital du Creusot, and in France. I don't know if it pronounced that in the right way or not. And the former chairman of the IDF MENA region, the former chair of the IDF Diabetes and Humanitarian Sitting Committee, the former president of the Syrian Endocrine Society, and the former president of the Arab Group for Study of the Diabetes, and the former vice president of the Mediterranean Group for the Study of Diabetes, and the former administrative director of Syrian Center for Tobacco Studies, and the past vice president of the Syrian Diabetes Association. He has many publications on diabetes, disaster, epidemiology of diabetes, diabetic foot obesity, and thyroid disease. Dr. Al-Bash, it is a pleasure to have you today with us, and the podium is yours. Go ahead, please.
Thank you, Dr. Muhammad, for this nice introduction. And I'd also take this opportunity to thank the Secretary Association for inviting me to present something about education on diabetes, particularly our colleague and friend, Mr. Abdulaziz Ahmedi. Well, actually, you know, maybe you heard about that. Today, the IDF put the World Diabetes Day under the slogan, nurses make the difference. So we are going to talk about the importance of nurses in education program worldwide. First, maybe, yes, okay. So this is my slide, if I can go through. Okay, so first of all, let's say that diabetes was discovered in our region 1,500 years ago by Egyptians in this very old papyrus. They was talking about diabetes. This is a very important issue, that diabetes was discovered in our region. But during 3,500 years of history, with all civilizations and contributions worldwide, we didn't arrive to solve the problem of diabetes. We still have many people live with diabetes. Why? Because diabetes, you know, it's a chronic and epidemic disease with increasing prevalence worldwide. Also, because there is many complications, acute and chronic complications, diabetes. That's also diabetes is the main cause of death under the age of 60 today, particularly in Western and even worldwide. Also, it's a very costly disease. Spent to deal and treat complications of diabetes are very expensive. There is many risk factors, particularly in type 2 diabetes, interfere with the complications and everything. And lastly, we can say today we are not able to prevent or to cure diabetes, even with all the medications and technology we have in our hands to cure and prevent complications. The first question coming into my mind, why we didn't succeed to treat all these complications or prevent diabetes or to halt the epidemic of diabetes? Well, actually, the answer, we didn't succeed because diabetes became, as you know, worldwide epidemic with more than 415 million people living with diabetes. And we're expecting more than that in 2014. Now we have 1 of 11 people living with diabetes. In 2040, we will have 1 of 10 people with diabetes. In our regions, the prevalence is higher than other regions. Look to this slide. I'm not going to the details, but only to show the importance of diabetes. And if we have a huge and high prevalence of diabetes, this is due to many risk factors like discovery of oil, our region, particularly in Gulf area, with the abundance of local diet, particularly Mediterranean diet, which was very good and healthy. Now we adopt high calorie, high lipids, fast food. And in the same time, we have many lifestyle changes, low physical activity, obesity, smoking, high life expectancy, and now it's become very common. So with the age, we are more able to develop diabetes. And we have in our region this habit to marriage among relatives. So if we want to decrease the prevalence of diabetes, we have to deal with all these problems of diet and nutrition in our region. And I believe even in our region, fast food became very common. Look to this slide and you will see how it's common now, this fast food. And now we're coming with COVID and delivery with fast food at home. This is a bad image, what we could be, and we became in some way in our region. Remote control in one hand, cigarette in the other hand, and looking for TV. So we are coming to my next question. Did we succeed in some way to decrease at least diabetes complication? The answer again is no, no. We still have a very high rate of complication, diabetic ketoacidosis, hypoglycemia, and particularly chronic complications. Look for complications, eyes complications, neurological complications, kidney complications, and heart complications are very common. And the main cause of this among people with diabetes, particularly with type 2 diabetes. But now today, in 2020 and 2021, we can say the diabetes management is based on diet, which is very known and very old way to deal with diabetes. Lifestyle modification, which are needed, and we need to change a lot and work on that. Like coming back to our Mediterranean food, which is known to be very good for preventing diabetes and also help to lose weight. It's known with high consumption of bread, pasta, rice, moderate amount of grilled steamed fish, olive oil, small portion of lean meat, and many composite of and antioxidant. So we can deal with that. And we need for more than that. Medical treatment, I'm not going to do that, and control diabetes, hemoglobin A1C above under 7%, and blood pressure had to be controlled. And lastly, lipids profile should be also in a good control. And that's why we can prevent and detect complication very early. But most importantly, if we are doing all that, we are not doing all the job. We have this medical treatment, and we remember the discovery of insulin 100 years ago, and we have a lot of medication. We know about all this, starting with insulin discovery until today. But even with that, we still need more. What we need? Education for diabetes is not anymore something secondary. It's something very important, and we call that now therapeutic education. It's a part of diabetes management. It's not something we have to add. It should be included in every way, every type of treatment for diabetes, type 1, type 2, at home, at office, at hospital, everywhere. We cannot imagine anymore diabetes management without education adapted to your situation, but we need it. And this is not new. You have to know it's very important to have this education. And nurses in particular have a huge and very important role to play in diabetes management. It's a very active role. Now, diabetes education is not new. Bouchard in France, long time ago, described how type 2 diabetes can monitor glycosuria. Jocelyn in 1919 described for the first time the mutual role of diabetes and patient, how can collaborate together to control diabetes. Later on, I will focus on the role of Jean-Philippe Assal in Europe, who is the godfather of diabetes education in Europe. I personally start my career in education of diabetes in Geneva with Assal, and I know how it's important to start that in many countries. For myself, I introduced diabetes education in Syria 20 years ago. This is Jean-Philippe Assal, our let's say our first educator in Europe, and he's very known for that. So diabetes education is very important because diabetes, as I mentioned, is a chronic disease, but also because people with diabetes need to accept that diabetes. There is a very important role of educator in this important point. Need for diet, need for lifestyle modification, need also to make people involved in the management of diabetes. Their involvement and participation is crucial to get results. Patients with diabetes couldn't be anymore witnessing what's happening and only listening. He should in some way participate on this treatment and management. And we can reach at some point self-glycemic control for most of people with diabetes. And we can improve quality of life. And most importantly, if you want to go through more details about the prevention and the whole problem of education, we have at the IDF what we call the IDF standard for diabetes education. I will recommend you to see that on the text. But let me see now today what are the goals of diabetes education. Of course, the most important one, many aspects of diabetes, lifestyle changes, diet, oral treatment, injection technique and medication, glycemic control, self-management, and new technology coming. We heard something about CGMs, and insulin pumps, and so on. And we are arriving to closed loop today. And so there is many techniques to learn, and there is a huge important role of nurses to help people with diabetes, to teach them and to help them to understand all these issues. Also, educator can help people how to improve their food intake. Exercise is very important, and we have to explain for them to how to treat or how to decrease their stress with diabetes and how to take the medication, how to monitor their diabetes also. So the ultimate goal is to make people with diabetes reach their goals and to get their glycemia in targets. It's not easy, but through all these steps, we can improve our diabetes control with the collaboration and participation of our educators. So educators could help and provide tools and support to patients to manage their diabetes. But an educator could be a nurse or some other categories. And now we have more important role of educator. Educator is not anymore an expert giving information. It's more than that. He is a facilitator, help people to learn why they can need to know and support through changes required with diabetes. Maybe it's more complicated role, but they have to understand that a clinical part of the role, educational part, and psychological component of diabetes could be done by nurses. This role of facilitator is really what we see today in Europe and USA. And I just came from a hospital. We were organizing every week some kind of workshops, and many nurses are participating in this workshop to explain every aspect of diabetes. So people with diabetes are participating, listening, and playing a very important role to understand what's happening in diabetes and how to deal with that. Also, nurses who want to be an educator should have some skills, like analytical skills, to analyze what's happened with diabetes, understand diabetes, changing insulin dosage, adjusting blood glucose goal, updating insulin to carbohydrate ratio. We heard something about that with the CGMS, but also for type 2, for people with oral medication, they have a very important role, and they have to learn the skills to help people with diabetes. And most importantly, you are working on a team. They should have a role of communication between patient and doctors and other team members. Last point, it's very important to make attention to details regarding glycemia, glucose, injection sites, and so on, something that nurses are very able to do that once they make attention to those details. So you should also know a lot about diabetes, because sometimes people asking questions about their diabetes, and nurses who are educators should answer to all these questions. Some of them should have leadership skills that mean in some way could play a role of leader between all educators and group of patients for education. So it's very important. This is some issues that nurses, educator can deal with that: insulin storage and use, insulin injection, timing, needles, lipodystrophia, insulin pumps and technique, CGMS, and dosage adjustment, and more and more. I'm not going to all that. Who can be educator? Of course, doctors, but you know, I know myself that most of doctors don't have enough time to make education themselves. And once they do that, they do it very badly. They are really don't have enough time. They have a lot of patients at the waiting room, and sometimes they do that very quickly and maybe badly. So I would recommend to have at least one educator, and nurses could be the most a good one, because they know a lot of medicine, treatment, management, and connect very well with doctors. So I believe a nurse educator could be a good solution for your team. Of course, dietitian could be another, podiatrist also, physiotherapist, and patients themselves could be educator also. Why not? A structure for education could be some kind of lecture, focus on group motivation, interviewing, self-management education. And this is the most important thing to know. Education could be different from one region to another, from one country to another. And the best way is to choose what is good for your patient according to their level of you said education and knowledge and so on, and culture. So education could be organized in hospitals, in patient setting, or outpatient services sometimes, and local diabetes association. I know that at Sikari you have a lot of the education programs, and I encourage to continue to do that. Even in pharmacies, they could do that. Home care nurses, individual home, community centers. It could be some kind of group or individual education. What are the benefits of education and awareness? And I believe this is the most important slide in my presentation. Education will help us to understand treatment, and we have better adherence, patient adherence to treatment, better diet. The education helped to change lifestyle, increase activity, and decrease stress. This will allow us to have lower A1C with education. It's proved good education is a good tool to decrease A1C. And of course, we'll have less acute complications per se, less hypoglycemia when you have uneducated diabetic people with diabetes. Hospitalizations are less, and most importantly, we are improving quality of life with education. Finally, we can reach our goal to decrease the chronic complication of diabetes and maybe the cost to manage diabetes. So it's not a small thing, it's a huge benefit once you have education in your team. But still there is many changes regarding education and educators. That education varies from one country to other according to many factors, local facilities, local income, healthcare organization, hospital, outpatient, and so on, and cultural and religious beliefs. Vary from rural to urban communities, we understand very easily that it's more easier to organize something in urban communities, more difficult in rural areas. And it has become recognized now that educator is something important by his authority. But in the past time, it was difficult to convince them to introduce educator as a part of diabetes team management. And still in some countries, there is no certification for educators in many countries in our region. And also the cost, maybe it's not an issue for Saudi Arabia, but I know in other countries, is nobody paying for or giving money for education to organize some issues. Also, there is a cultural issue, and this is very important. What I noticed myself from my own experience, that in Middle East, people with diabetes don't like to come to education program. Said, okay, what you are going to explain me how to eat, how to move, I know everything, I don't have time. He considers that something very secondary and not very important. And you have to attract them by many ways to let them come and to follow your programs. The absenteeism of this kind of programs in our country in Syria was very high. So we have to be creative to find a way to motivate these people to come and to follow the programs education in our region. It's opposite now in France, most of people seeking to get education in our hospital. It's very requested, and we are organizing every week a group program education for many groups. So I believe it depends also in cultural, also and some beliefs in the region. So, but we can with that, if we can work with nurses, with our team, we can improve the education in our region. And to conclude, I would say, I believe maybe I discover more in Europe, in France currently, where I'm working since 5 years, that nurses could play a major role in diabetes education programs. Thank you for listening.
Thank you very much, Dr. Nizar Al-Bash, for the presentation. I don't see any question posted in the chat window, but I see somebody who is raising the hand. Amr Al-Sukari, do you have a question?
Is there any question?
Yeah, I see somebody's raising the hand, but they're not responding. Amr Al-Sukari, do you have a question? If there is no question, thank you again, Dr. Nizar, and it was a pleasure to have you today. So we'll move to the next presentation by Professor Hanan Al-Fawaz.
Thank you. Bye-bye.
Who is a professor in nutrition and metabolism at the Food Science and Nutrition Department at King Saud University in Riyadh, Saudi Arabia. She is a member board of biomarker of chronic disease at King Saud University. She is a board member also of the Saudi Charitable Association of Diabetes. She has over 60 published papers in international journals with high impact factor, and she is a speaker in national and international conferences and meetings. Without further ado, I welcome Dr. Professor Al-Fawaz today. Please go ahead.
السلام عليكم ورحمة الله وبركاته. الصوت واضح؟
واضح، شكرا.
السلام عليكم ورحمة الله وبركاته. الحمد لله رب العالمين والصلاة والسلام على سيد المرسلين. First of all, I would like to thank the Saudi Association.
Professor Hanan, your voice goes up and down. I don't know what's.
Okay.
If you can, bring the mic closer to your mouth, maybe that will help.
What about now? It's okay.
It's a bit low.
Oh. I don't know. Now it's clear.
It's better, but if you can raise it a little bit, that would be great as well.
Okay. This is one. Okay. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على سيد المرسلين سيدنا محمد عليه أفضل الصلاة وأتم التسليم. First of all, I would like to thank the Saudi Charitable for Diabetes and the Scientific Committee for nice invitation. Thank you, Dr. Medel, for nice introduction. Thank you all the audience who joined the webinar and joined us today. Special thanks to Mr. Aziz Al-Hamidi. My presentation today, it will be about lifestyle management is a key to treating a patient with diabetes. The goal for treatment always for diabetes to prevent or delay complication and optimize the quality of life. Provide the communication with patients and families should be acknowledge multiple factors impacting glycemic management and in phases to the collaborative developed treatment plan to healthy lifestyle, which is significantly improve disease outcome. And the goal for the communication with the patient is address the self-management barrier without any payment for the patient for non-adherence or non-complaints. In many settings, unfortunately, and some specialized diabetes center, which get the best, just give the menu for the patient, and that's all. Urgent investment in the fast food industry, like urbanization, direct-to-consumer marketing of food high in calorie.
Dr. Hanan,
Yes.
Sorry for the interruption, but again, we lost your voice. It goes up and down, and unstable.
Oh.
I don't know if the mic is you can bring it closer or something like that.
Well, it's closer now. I don't know what. Let me see. What about now? It's okay.
Yeah, now
this
is
is
good.
The highest.
Yeah, now is good.
Okay, because this is the highest. Okay. Sorry for that. Shall I repeat the other one? It's okay. It's clear. Last slide. Shall I start from the beginning, Dr. Mohammed?
You can continue, but we lost it again. I'm sorry to say that, but
now,
we lost the voice again.
I don't know what's happened. Sorry. No, it's okay. Okay, so and the effect of this factor on nutritional lead to obesity and type 2 diabetes and existing undernutrition and micronutrient deficiency. Modern lifestyle characterized by physical inactivity and long sedentary life for a long time. So while there are a number of factors influence the development of type 2 diabetes, there is the evident the most influential lifestyle behavior. A study from different parts of the world established that life modification, which include physical activity, healthy diet, can delay or prevent illness from type 2 diabetes. Healthy lifestyle can improve health outcome even at later stage of life. The population-based intervention and policy allow healthy choices through policy in trade, transport, urban planning to become more accessible and easy. Healthy choices can be promoted in a specific setting, even in the workplace or the home, in the school, to contribute to better health for everyone. It includes regular and eating wisely, with maintain normal level of blood glucose and blood pressure. Diabetes care should be managed by multidisciplinary team that may draw from primary care physician, subspecialty physician, dietitian, nurse, practitioners, physician assistant, exercise specialist, pharmacist, dentist, nutritionist, and mental health professional. Lifestyle management and psychosocial care are the cornerstone for diabetes management. So the patient should be referred for diabetes self-management education, support, and medical nutrition therapy to assess psychosocial emotional health concern. For the risk factor for type 2 diabetes, there is modifiable risk factor and unmodifiable risk factor. Modifiable will be lack of exercise, overweight, and unhealthy eating, which we can change it. But with the unmodifiable is family history. So the cornerstone for treatment of the patient with diabetes is lifestyle management. Lifestyle intervention, even for the pre-diabetes patient, it insists that even maintain the loss of 700% of nation body weight and engaged in physical activity, like at least 150 minutes per week. It's very good result for the patient with pre-diabetes to refer to be normal. A variety of eating pattern also are acceptable for a person with pre-diabetes. It's based on what the patient prefer. The technology assessment diabetes prevention and intervention may affect to prevent type 2 diabetes. There is overwhelming evidence from study from different parts of the world, like USA, Finland, China, India, and Japan. They find lifestyle change. It's very good to help prevent or develop type 2 diabetes. There is some study done which show that lifestyle intervention reduce the incidence of type 2 diabetes by 58% over 3 years, followed up by 3 large study of lifestyle intervention. They found also they can reduce honest diabetic by 39 reduction at 30 years and 43% reduction in 7 years in finished diabetes prevention, and also in 34% reduction at 10 years and 27% reduction at 15 years in US. We done, this is one study conducted by me and my team about the reversal of diabetes in Saudi adults. And this is lifestyle intervention demonstrated that we can reverse Saudi adults to be pre-diabetes to be normal status only by affecting through lifestyle than the standard care. And another study, we for 12 months intensive lifestyle program compared with general advice, and we found that it's very effective to include an intensive lifestyle program for decreasing weight and improve fasting glucose. Another study also conducted by me and my colleague, the study showed us the beneficial effect of 6 months lifestyle modification program to improve macro and micronutrient intake and physical activity among Saudi adults with pre-diabetes. Also, we found an intensive lifestyle modification compared to low dose of metformin for a period of 12 months significantly reduce the metabolic syndrome manifestation in individuals with pre-diabetes, which lifestyle modification being superior to metformin. So pre-diabetes, at least, we should go on annual monitoring for this patient not become diabetic. Patient with pre-diabetes should be referred to intensive behavior lifestyle intervention program by diabetes program prevention to achieve or maintain 7% plus initial body weight and engage in physical activity to at least 150 minutes per week. With the revolution technology, we can use it, this tool to include in the internet-based social network, distance learning, and mobile application. There's a lot of mobile application. So we can incorporate with and communicate with the patient to useful for effective lifestyle and follow up with them to prevent diabetes. There is like terminology therapeutic lifestyle, which is called TLC. This is the component of this one. It's like to be healthy, healthful eating, limited alcohol consumption, stress reduction, avoidance of tobacco, and sufficient sleep. So if we can see this recommendation for therapeutic lifestyle change, the parameter weight loss, as I said before, reduced by 5 to 10%. Some studies show even reduce the initial body weight from 3% to 4%, it will be useful. Physical activity, as we said, 150 minutes per week, with exercise and flexibility, strength training, a diet, like consuming a plant-based diet full with antioxidant, polyunsaturated fatty acid. The most important, understand the nutrition fact label. So to teach the patient how to read the label for the product, to know if it is good for him or her or she or not. Use a mild cooking technique instead of high heat cooking, and keep a physician-patient discussion informal. Also incorporate the beliefs and culture into discussion. For the carbs, we recommend that the healthful carbs, which is include fresh fruit, vegetables, legumes, with low glycemic index, fat with healthy fat like in avocado nuts, certain planet or fish, limited saturated fatty acid, protein consumed protein in food with low saturated fat like fish, beans, avoid limit processed meat, micronutrient. Routine supplementation is not necessarily unless the patient is at risk of insufficiency or deficiency. This is some table just to explain what does mean the glycemic index of common food. This is like average from 0 to 100. How to the food raise the blood sugar fast. So when it is less than 55, it will be good to increase the blood glucose slowly. There is another terminology like medical nutrition therapy, which used in Europe and the USA. The evidence suggested that there is no ideal percentage of calorie from carbs and protein and fat for all the people with diabetes. So it is dependent, as I said before, individualized in the person, how it is he prepared, what's the metabolic goal for him or for her, consider personal, traditional, culture, religion, health benefits, and economy, and what the metabolic goal when working with it. Refer to a registered dietitian or nutritionist is essential to assess the overall nutrition status and to work collaboratively with the patient to create a personalized meal plan. And this is what I assist, not to make it in the group or not the same for the adult. We have to be individualized, what's the preferred for the patient to have a good income out. Recommendation for medical nutrition therapy, it's weight management, exercise, increase glucose monitoring, consistency for carbohydrate intake, adjust insulin dose to match carbs, and adequate protein intake. This is like a table. It explains the lifestyle therapy for the complication of diabetes. Also, we find that it's insists on nutrition, physical activity, sleep about 7 hours per night, behavior support, community engagement, smoking, not smoking. This is diagrams to show how can we have to concern about the people with the type 2 diabetes. What's the goal? What's the medical goal for them to have a very low calories diet, glycemic control, and adjustment with medication, if any. There is a facilitated behavior change and well-being to improve health outcome. There is some tips for the diabetes self-management education and support, which is said that all people with diabetes should be participate in diabetes self-management, receive a support need, facilitated knowledge, decision making, skill mastery necessary. And there are 4 critical times to evaluate need for diabetes self-management education, diagnosis and annually when the complication factor varies and when transition care is occurred. Language. We have to be careful with the language we use with diabetic patient. 5 key recommendations for language. The language to be neutral, non-judgment, based on facts, action. Use a language free from stigma. Language's strength is respectful and inclusive, and that improves hope. Factors collaboration between a patient and the provider. Use a language that person-centered. Example, person with diabetes is preferred than diabetic. The physical activity, as we said, the children and adolescents with type 1 and type 2 diabetes should engage in 60 minutes per day for moderate to vigorous intensity aerobic activity and strengthening, bone strengthening activity at least 3 days per week. IDF recommended physical activity at least between 3 to 5 days a week for a minimum of 30 to 45 minutes. Adults with type 1 diabetes should engage in 2 to 3 sessions per week resistant exercise. All adults, and particularly those with type 2 diabetes, should decrease the amount of time spent in daily sedentary behavior. So prolonged sitting should be interrupted every 30 minutes for blood glucose benefit. And there is like terminology today, and with some study they said sitting disease. That means the more sitting is the more disease. Flexibility training and the balance training are recommended between 2 to 3 times per week for all adults. Increase the flexibility and muscular strength and balance. For patient to achieve a short-term weight, it depends what we need for this patient. Is it short-term weight loss or long-term? We need like a 5% short-term, 3 months or 1 year. It depends what's the goal for this patient. So what will be the nutrition advice for them for low calorie diet like less than 800 per week to maintain weight loss, and use programs must be incorporate long-term comprehensive weight maintenance counseling. So the formula for good health: 0 cigarettes, 5 serving of fruit and vegetables per day, 10 minutes of silence relaxation to relieve stress, 30 or less for the BMI, 150 minutes, this is the less for exercise per week. This is some chart for the component of the medical evaluation, which use the nurse and the doctor for the patient with diabetes, and we can see the lifestyle factor. It's the most important to do it in initial visit and follow up and annual visit. Thank you all, and wish everybody today a healthy life. Thank you.
Thank you very much, Prof. Hanan, for the lecture. I don't see again any question in the chat. Dr. Hanan, can I ask you a question about resistant exercise?
Yes.
It's 2 to 3 times per week. For how many minutes? Did they specify for how many minutes?
Yes, they specified by 5 to 10 minutes. It will be okay. So the more as tolerate, because it is depend in the health and the performance for the patient. But it's from 5 to 10 minutes, it will be.
Okay, thank you very much. If there is no question, we'll move to the next presentation by Ms. Aisha Al-Mtairi. She completed her bachelor degree in health education from King Saud University in 2015 with second-class honor. She is currently a diabetic educator in the specialized diabetes clinic at King Khalid University Hospital. She attended many local and international conferences and participated in many community services. Aisha, it's a pleasure to have you today with us, and you can please proceed with your presentation.
Assalamu alaikum jami'an. Good evening. Thank you for organizing committee to having me today with you. I can't share my slide.
Prof. Hanan, can you stop sharing your slide so can Aisha share the presentation? Prof. Hanan, do you hear us? Yeah, okay, thanks.
Okay. It's clear now?
Yeah.
Okay, today, inshallah, we will talk about role of diabetes educator in diabetes management. Our outline, we will talk about traditional care model versus patient-centered care. We will talk about who's diabetes educator. Do we need diabetes educator really in our clinics? How can diabetes educator help patients? Role of diabetes educator and scope of their practice. We will talk about challenging facing diabetes educator and the new title by the Association of Diabetes Educator. And we will close, inshallah, with real case in our real case in our clinic. Diabetes is a complex chronic illness requiring continuous medical care with multifactorial risk reduction strategies beyond glycemic control. Ongoing diabetes management, education, and support are critical to preventing acute complication and reducing the risk of long-term complications. A traditional care model, which is one direction from the healthcare provider directed toward the patient, using strict language in providing instruction like do or not to do, ignoring the role of the patient in managing his condition. In this care model, rarely can help a patient in managing their condition. Management of a chronic condition such as diabetes required engaging the individual to take an active role in self-care. Motivation to self-management may not be as popular or as common because we know that a symptomatic patient may be motivated to control their disease to relieve the symptoms, but in diabetes, because the absence of symptoms may reduce the motivation, the patient's motivation to self-manage their disease. A wide body of evidence now demonstrates the knowledge alone is insufficient to promote behavioral change. In the last year, the healthcare system is being focused on patient-centered outcome, which required active engagement of both patient and healthcare provider. Multidisciplinary team. People with diabetes can benefit from a coordinated multidisciplinary team that may draw from diabetes educator, primary care provider, subspecialty provider like nurses, dietitian, exercise specialists, pharmacists and dentists, and mental health professional. Diabetes is a complex condition that requires ongoing care management through interdisciplinary collaboration across the continuum of care. Who's diabetes educator? Diabetes educator are healthcare professionals who apply in-depth knowledge and skills in the biological and social science, communication and counseling to enable patients to manage daily and future challenge. Diabetes educators are integral in providing individualized education and promoting behavior change using a framework of 7 self-care behaviors known as AAD 7 self-care behaviors, which are provided by Association of Diabetes Care and Education Specialists. What is this care behaviors? It's healthy eating, being active, monitoring, taking medication, problem solving, healthy coping, and reducing risk. Diabetes educator may be from a quite different clinical background. Most common here in Saudi Arabia are health educators, public health, a clinical dietitian, pharmacist, or nurses. Do we really need a diabetes educator in our clinic? If we talk about providing information, every single member of multidisciplinary team can provide the knowledge and the skills and competency and support. But due to increasing diversity and complexity of care, limited time for healthcare providers, especially those who work in primary care setting, and also the importance to provide tailored and structured education. How can diabetes educator help patients? Studies show people who receive diabetes education are able to be proactive in their care, able to take medication as prescribed, able to control their clinical indicator like blood glucose monitoring, like blood pressure level and LDL, also have lower health cost. Role of diabetes educator. The role of diabetes educator has changed from expert who just provide information and instruction to facilitator who facilitate and empower patient to be effective self-manager. The diabetes educator has a complex role that combines the clinical, educational, and psychological component of diabetes care. Work as part of the patient healthcare team to engage with the patient in informed decision making. Provide support and counseling through life change after diagnosis. Help individual to develop a positive psychosocial adaptation needed to achieve effective self-management of diabetes. Diabetes self-management education, which is referred as DSME, is a collaborative process through which people with diabetes gain the knowledge and the skills needed to modify their behavior and to self-manage successfully the disease and its related condition. In accordance with National Standard for Diabetes Self-Management Education, All people with diabetes should participate in diabetes self-management education and training and receive the support needed to facilitate the knowledge, decision-making, and skill mastery necessary for diabetes self-care. Scope of practice. Diabetes educator in a variety of practice setting and role, their practice is underpinned by a core body of knowledge, skills, and activity in the following domain. First, in the clinical practice, which is providing diabetes self-management education and training for the patient, research and evidence-based practice, management and administration and leadership. Today, we will focus on clinical practice, which is providing diabetes self-management education and training. We know that the heart of what we do is teaching, coaching, and guiding people with diabetes, beginning with helping them learn about basic information, which is started with what is diabetes to food care. We assist patient to acquire and develop the skills needed. We teach and train them on the best ways to use their blood glucose meter, insulin pens, insulin pumps, and CGMS. Educator also help patient in adopting healthy habits and make real world change to their diet and lifestyle, including meal planning and weight loss strategies. We also help people with diabetes develop problem-solving skills and coping strategy when life situations change. And of course, when we dealing with chronic disease such as diabetes, it's important to teach patient coping mechanism and give them strategy to overcome obstacles. We help them learn how to monitor their blood glucose and interpret and also respond to the result. We also teach the patient important information about how their medication works, why it's important to take medication on time, and how to deal with side effects. There's some challenge facing diabetes educator, some related to patients themselves and some related to the healthcare system. The one related to patient themselves, some patients, they believe that they know enough about their condition. They don't need an educator to teach them, especially those who had diabetes for several years and they never met the diabetes educator before. Some of them, they don't believe in the importance of diabetes self-management education. Some of them are emotional shocked at diagnosis. Especially for teenagers, some of them relying on family and friends. The challenge related to healthcare system, of course, shortage in number of diabetes educators in our country, lack of reinforcement on the importance of diabetes education. The new title, Diabetes Care and Education Specialist, it's a term by Association of Diabetes Care and Education Specialists, because not all about self-management, not all the role of diabetes educator in self-management. Our role maybe hello, it's clear.
Aisha is still there?
Yeah, there. The new title is Diabetes Care and Education Specialist. We know that self-management care and education is the heart of what we do as educator, but that is not only the things. So American Association of Diabetes Educator come with a new title, which is Diabetes Care and Education Specialist. They rebrand their association to Association of Diabetes Care and Education Specialists. All that to inspire care team as we elevate the future of an entire specialty. The new title help to bridge the gap between the clinical and self-management aspect of care. Okay, real-time case or real case from our practice. This is one patient who referred, she is a 25 years old lady, type 1 diabetes for 16 years, celiac disease and dyslipidemia, complicated with retinopathy and proteinuria. Her A1C before, in December 2018 was 10.9. AC ratio was more than 8,000. I still remember when this patient referred to our clinic from nephrology, our colleagues in nephrology department. She was frustrated, crying in the clinic. She was not motivated at all to change or to do anything about her diabetes. She had some bad history with her primary care physician before, so she wasn't taking her insulin at all. When we talk with this patient, she asked us, she was not motivated at all. She was telling us, if you want to help me, just give me a final cure for my diabetes. During assessment period, we found that she is really lack of that basic diabetes information. And after counseling her, she agreed to start diabetes self-management education and training. We start her from zero. This is her AGB report, first AGB report in our clinic. After that, in August 2020, she reached 81% target range. Her A1C was in September 2020. Her A1C was 6.8. AC ratio dropped to 1,400. The beauty of this report that she's the one who managed her diabetes totally here. She's the one who choose and she's the one who choose when and how much to take insulin or carb. And this is all after completing the diabetes self-management education and training. Summary: effective diabetes management requires more than a knowledgeable clinician. It should also include the incorporation of a strong and focused healthcare team with all team members, including patients themselves. The diabetes educator has a complex role that combines the clinical, educational, and psychological component of diabetes care. Self-management is an important concept to emphasize. This is word from our patient after receiving the education. And thank you.
Thank you very much, Aisha. Your presentation just highlight the importance of the diabetes care and education specialist in the care of our patient. Thank you very much. I will open now the floor for questions. If you have any question, just type in the chat box, please. Seems that there is no question. I thank you for all the attendee and thank you for our speakers today. I will leave the final word with Abdulaziz Al-Hamidi, the director of the Saudi Charitable Association of Diabetes. You can go ahead, Abdulaziz. Thank you.
السلام عليكم ورحمة الله وبركاته. أسعد الله مساءكم. لا يسعني في هذه اللحظة وفي ختام هذه الندوة عن التمريض والسكري إلا أن أشكر الأخوة المحاضرين والمحاضرات على الجهود المبذولة في إنجاح هذه الندوة. ولا يسعني إلا أن أشكر سعادة الدكتور عبد الرحمن المغامسي المنسق لهذه الدورة وهذه الندوة، وكذلك الدكتور محمد المهدل، وأصدقائنا كل من الدكتور محمد صنديد والدكتور مصباح كامل، وكذلك إليزابيث أبو جودة والدكتور نزار الباش، وكذلك الأخوان البروفيسور حنان الفواز والأستاذة عائشة المطيري، وكذلك جميع الأخوة والجميع الأعضاء واللجنة العلمية، وكل من سعادة البروفيسور الدكتور ناصر الداغري، وكذلك الدكتور محمد الحربي والدكتور ناجي الجهني. أشكر الجميع على ما قدموه في هذه الندوة، متمنين الجميع إن شاء الله الصحة والعافية، متمنين أن تزول هذه الجائحة وأن تروح هذه الغمة، ونسأل الله لنا ولكم التوفيق في جميع المهام. أشكر الجميع على الجهود اللي قدموه في هذه الندوة، وإن شاء الله لنا لقاء قريب، والله يحفظكم ويرعاكم.
شكرا أستاذ عبد العزيز، وإن شاء الله نتطلع إلى كونفرنسز جاية إن شاء الله بإذن الله بعد ما تزول إن شاء الله الكورونا.
شكرا
إن شاء الله.
وإن شاء الله بتكونوا كلكم بصحة جيدة يا رب.
يعطيكم العافية جميعا.